I know it sounds like a fair number of folks in the audience are medical providers, with some people providing psychosocial peer support or other folks. So hopefully this is just sort of a brief overview of cognitive behavioral therapy. The reason why we want to do that is because this is one of the evidence-based models recommended for patients with substance use disorder, and as well as opiate use disorder in terms of a psychotherapy. And one of the things that I like to convey to folks in the learning community is that not all therapy is the same, that we really want, when possible, be linking and making recommendations for patients to evidence-based psychotherapies. Supportive psychotherapy can be very effective for many people. Unfortunately, for a large percentage of the population that we treat here at ASAP, and I'm guessing that many of you treat, our patients really do need some concrete skills to be able to manage their use, to kind of get unstuck before supportive therapies are really going to be as helpful as they can be. And so thinking about making recommendations for cognitive behavioral therapy can be really great. And so I wanted to provide just an overview of what is that, so you know what you're referring to. And then also very briefly show you some examples that fall under the relapse prevention umbrella, which actually lives within a CBT model. So that way you can kind of understand some of the techniques that would be used in that therapy and what is that therapy about. And the last time I talked about the stages of change model, and hopefully some of the takeaways is understanding, okay, where do these different therapies sit? So relapse prevention is really best used once patients have entered action and are really entering into maintenance. So you can start it in action, and then once people hit maintenance, because these skills are intended to help people. They can be used to decrease use, but they're really most effective once people have slowed down their use or have stopped their use, and they're trying to just maintain for the long term, because that's a really major change. And so oftentimes these skills that fall under CBT can be really, really effective. Another way of thinking about where this fits in terms of the timeline of treatment is once people are early in recovery or they're highly symptomatic, they're using at high levels, we really want to employ some harm reduction techniques. And some of those can fall within CBT, but harm reduction is atheoretical. It's not really part of the CBT framework. So CBT is most effective once patients are not pre-contemplative. They're entering into a phase in their recovery where they're really wanting to learn some skills to identify triggers, to do high-risk situation planning, and to really start to make some concrete changes with their behavior. And then relapse prevention skills are employed once they're practicing that basic CBT stuff, and they're able to maintain those changes that have been made. So what does this look like? What does actual CBT therapy look like? Well, it's a talk therapy that, in a nutshell, teaches patients how to link thoughts, feelings, and behaviors together in a way that makes sense. It has really good evidence for treating all kinds of substance use conditions. The other nice thing about it is it's really flexible. So what does that mean? That means that you don't necessarily have to do a full protocol, a full 3 to 6 month protocol. You could actually pull pieces out. Okay, I got kicked out. Let's try that again. So this is showing you, we call this the CBT triad, even though you'll see 4 things on here. In a nutshell, what this is explaining, and most of the techniques that we're teaching within CBT is explaining to folks that there is a activating trigger. It doesn't necessarily have to be environmental. It could be internal, but for a lot of folks, it's out there in the environment. I'm going to talk a little bit more about that here in a second. And that trigger causes this cycle to activate. So they're triggered, then they have a thought, and then that thought impacts an emotion, and that emotion impacts their physiology, so bodily sensations, and then that impacts behavior. And you can see that these arrows are bidirectional. So this really is a cycle. So I can have a thought that links to an emotion, to a body sensation, to a behavior, or I could engage in a behavior that links to a thought, that links to emotion, and so on. So this really, you think about it as a cycle. And a lot of what we're doing in CBT is teaching folks how to intervene at the levels at where they can actually make changes, which has to do with their thinking. So changing the thoughts that they have will then change the behaviors that they engage in. And then changing the behaviors that they have will then change the thoughts, right? So it's bidirectional in that way. We can't do too much with emotion. Once the emotion is there, it really just needs to run its course. So what we're teaching patients what to do is how to intervene at those two ends, right? How can I change my thinking, and how can I change my behaviors to lead toward less use or sustained recovery, whatever that looks like for that patient. So CBT is really intended to be highly structured. So the sessions are broken into 20 subunits within a 55 to 60 minute session. This is traditional CBT. Really what we're trying to do is this balance between being directive, but not overly directive. So having an agenda, teaching specific skills, and also being supportive and empathic and accepting of where the patient is at. So similar to a really good teacher, you come in with a lesson plan, you have things that you want to accomplish, but you also have to work with what's present in the room, and you have to work with the person in front of you and their learning style, and using different things to really help get that information, information across. So we don't want to be overly mechanical, but we also don't want to drift into just truly supportive intervention. So real quick to run through how this is set up, the first 20 minutes is where we set the stage. So you always come in with an agenda. So rather than how was your week, which is how sort of a supportive session might start, in a CBT session, we're saying, today we're going to talk about X, Y, and Z. What's that lesson plan for today? We're going to try to tie that into current concerns. So what's been going on with them in this past week so that it's relevant to them. And then review any prior practice. So a big piece of CBT is what they do in between sessions. And if we give them an assignment or ask them to do some practice and we don't check on that, then we haven't done our job. So the first 20 minutes is we talk about what we're going to do today. And then we move into reviewing, okay, what did you do last week? The next 20 minutes is where we introduce the new skill. So we really don't want to be introducing more than one skill per session, because we really want to spend that full 20 minutes talking about how it relates to those current concerns and practicing it in session. We do worksheets, role plays, all different various activities where they're really getting to work with the content. What is that skill that they're practicing? So that way, when we give it to them to take home to work with, they have experience of what it's supposed to look like and how to do it. And the final 20 minutes is where you're then checking for understanding, you're asking reactions to what you covered, you assign practice for that next week, and then you go over high-risk situation planning. And I'm going to show you an example of that here in a minute. CBT can be challenging. And so something to keep in mind when you're referring patients to this, or if you have patients that are in this protocol and they're struggling, it's that this is kind of a shift from a lot of therapies that patients have experienced in the past. And so getting them accustomed to, it really is more of a class structure than it is that I sit there and talk about and emote and sort of cover whatever it is I feel like covering that day. And it has that heavy practice or homework piece. And we always try to explain at the beginning of starting CBT, if you're not doing the practice outside of sessions, you're really not getting the benefit of this treatment. So one thing that you can do to really reinforce that with folks is to continue to reiterate those practice assignments. That's where the change is actually occurring. And so if they're not taking those assignments to heart, they're not practicing it in their daily life, they're really not getting the full dose or the full benefit of this treatment. And so continuing to encourage that is a big part of what CBT therapists need to do. We have to be pretty good salesmen in the sense that we have to convince folks and give them a rationale that they can hold on to as to why they should be doing this. So that comes to some of the things that we always want to be covering. Repetition is a hugely important piece. So we're never afraid to just repeat either an entire session or parts of sessions. A lot of things to keep in mind with working with people with substance use disorder: their cognitive abilities and their memory could be impacted by the substances that they've used. And what we're trying to overcome are habitual patterns, ingrained patterns that have been around for oftentimes a really long time, or at least practiced a whole heck of a lot. And so that's going to take a lot of equal effort to overcome and replace that habit. So repeat, repeat, repeat. The other big piece of CBT is always making sure that patients have a clear understanding of the rationale, what they should expect, both with that individual skill that you're teaching in that session, and what they should expect over the course of the entire episode of care. Why is this going to be helpful for them? And if clinicians are not good about stressing the importance of why, then they're really not going to be very effective at convincing patients to utilize these skills outside of sessions. So making sure that patients understand the rationale is super important. Another big piece is the monitoring. So good CBT always includes ongoing monitoring, both monitoring from session to session. So using something like a PHQ-9 or a DAST or an audit or some sort of a screener that collects data every single session to be able to track improvement or track change. But also teaching patients the tool of monitoring, how to log and track their use and their cravings and urges. I'm going to show you an example of that here in a second. We also want to be good behaviorists, and because what we're looking to do is change habits, we need to praise approximations. And this is something that can be helpful no matter what form of work you're doing with somebody, but recognizing that people don't change like flipping on a light switch. They don't go from doing a certain set of behaviors to a whole new set of behaviors overnight. They don't make that change with insight alone. Then in fact, what they're doing are successive approximations. You think about little kids that are learning how to walk or how to ride a bike, right? They do a little bit of it. They get close to it until one day everything just kind of snaps into place. So that's what's happening with people when they're doing behavior change. When they're moving towards a healthy change, they're making little shifts along the way until that kind of light bulb moment. And as therapists or clinicians or providers, we need to really praise those approximations, no matter how small they are, because if we don't highlight it, we're not going to continue to see that behavior reoccur. So making sure that every opportunity you have to be like, oh my goodness, you came in today, or oh my goodness, you did this, that's amazing. Give them pats on the back. That's really, really important. And then I already mentioned this before, but a big piece of what you're trying to do is overcome obstacles to practice. So making sure that that you talk about that avoidance to practice outside of session, and that you're always trying to determine what's getting in the way. Why is it that they're really struggling to apply this? And that's why it's built in to that first 20 minutes of a CBT session, to make sure that we're focusing on that outside practice so that they're really getting the most effective dose. Okay. So now I want to go over some relapse prevention CBT strategies that we might cover in a basic CBT for substance use disorder protocol. So one of the first things that we'll talk about with patients, especially early on in a protocol, is trigger identification, being able to understand those external and sometimes internal triggers that are part of that behavior chain. So teaching patients this particular line, that you have a trigger, something external or internal is sort of that pushes that first domino that causes a thought like, oh, I'm a bad person, or I'm never going to get any better, or God, if I could just get some relief, whatever that thought is, that is then linked to a craving, which could be physiological or emotional, that is then linked to the use behavior. So helping them understand you can intervene at the level of trigger and at the level of thought. So before those dominoes get pushed to use, you can do lots of different steps along the way. And you think about this, you explain it to them in the form of classical conditioning. So a lot of folks probably in school remember Pavlov's dogs. This was an experiment that taught that almost all vertebrates can go through classical conditioning, which means that there's an unconditioned stimulus like food that's going to cause salivation. We can partner that unconditioned thing with something that's neutral, that doesn't normally cause salivation. And if we partner it enough, eventually that neutral stimulus is going to cause that unconditioned response, the salivation. So this is happening with substance use disorder, the development of the disorder all the time. So every time somebody seeks out drugs or uses drugs or intoxicants, the environmental stimuli that's associated with that gets linked, just like the whistle and the food get paired. So over time, things like tinfoil or syringes or cotton balls or certain parts of town or, their dealer's house or certain smells or emotions, all of these things get linked to the effect of the drug itself and become a trigger to that craving and urge to use. So we want to be explaining that. And one of the ways we can do that is using a functional analysis. And that is a form that I'm going to show you here in a second that identifies all of the triggers and helps you to start to develop a high-risk situation plan. So this is an example of a functional analysis. So you can see it goes through the external triggers, the who, where, when do you usually use? What are those triggers, both thinking, feeling physically, and feeling emotionally? So you can kind of get both internal and external. And then kind of what are the consequences, negative and positive, that are linked to it. And this is going to then help you to develop a high-risk situation plan that you're going to go over with them every single week. Behavioral contingencies is another intervention that we use to sort of understand urges to use, and that's part of a CBT protocol. And that's really just understanding that people respond to consequences, both positive and negative. We know that rewards, so that sort of praising approximations or reinforcers, are going to increase a desired behavior and are going to be more long lasting. But punishment and sanctions also will decrease an undesired behavior. They just don't tend to last as long. So if we have a choice, we want to use rewards instead of punishments. But recognize that talking about or helping people think through the consequences, those negative consequences, can also be a powerful piece of really understanding what to do. So that's applying specific contingencies. So you can do this both as a program or as a provider, thinking about what are the behavioral targets, what are the behaviors I'm wanting to change. It could be something like attendance or their use behavior itself. And then what am I going to use to reinforce it, or what are they going to use to reinforce it? So here's an example of what's called an alternatives to use table that you would go over with someone to teach them how to do this themselves. What is the triggering situation? And what are the positive consequences of use? What is reinforcing my use in that triggering situation? And then what would be an alternative activity with a similar positive consequence? And sometimes you have to put multiple activities in order to get an approximation of the consequence of use, because we know that a drug is going to really hijack the brain and provide a level of euphoria, a level of distress relief that talking with a friend isn't quite going to equal, right? So sometimes you have to stack a number of things in the alternative category. But what this does is it introduces options for patients to be able to think through, if I'm triggered or I'm in this situation, there is something else that I could do in place of that use behavior. So starting to think about using reinforcers in day-to-day life. Urge management is another technique that's part of CBT relapse prevention. And this is where we're trying to teach them the skill of understanding how to identify and modify those urges, particularly at the level of thought, before they become a behavior. And so here's where you would use a monitoring sheet to have them actually write down what's the situation, the things that you're thinking, the things that you're feeling as a result of that thought, what's the craving intensity, and actually putting a number on that. And then what are the behaviors that you're going to use to cope with that situation without use? And then here's another monitoring log that includes use plus urges, right? So what are the urges? Were they present or not? And this helps to paint a picture, again, of what are those triggering situations? What are the things that we need to have a plan for? And one of the plans that could be applied as part of that high-risk situation plan are using techniques that fall under the umbrella of urge surfing or urge management. So that's where you're helping to explain to folks that urges are part of this process. They're going to come up. and that you really don't have to do anything about them except not respond. So some of the ways that you manage an urge are in the service of preventing you from responding to it, because the longer you can go without acting on that urge, without reinforcing it with the use, the less strong the urge becomes over time, and the less likely it is to be connected. So you're starting to break that connection between the urge and the use behavior itself. So helping them understand it's like waves. It can kind of like crash into you and then roll off of you. So it's time limited. And really, you don't have to do anything but wait it out, because they typically peak between 20 to 30 minutes. So if you can just hold on for that time period, then it will remit a little. You'll get some relief. It may come back just like waves in the ocean, but you know now that you can ride it out, that you can actually wait for it to pass. There are things that you can do, because 20 minutes can be a really long time for some people, to manage that 20 minutes. And so those are distraction techniques or thought techniques that can help to manage it until it becomes weaker. High-risk situation planning is the last thing that I want to talk about. And this is something that you do in a CBT protocol. You do this every single week. That's part of that last 20 minutes. And the reason why this is so important is because you're wanting to teach the skill of thinking through, kind of pulling all of that stuff together that I just talked about. Your triggering situations, what are the thoughts and feelings that are present, and then what are you going to do to reinforce health behavior instead of use behavior? How are you going to manage that triggering situation? So you think about it, this is like when we have fire drills in our areas. It's so that in case of emergency, we know where we're supposed to go, and we have to practice that. And it seems silly at the time that we're practicing it, but in a true emergency, in an actual fire, you're going to be grateful that you know where the stairwell is, or you know how to get out of that building safely, and you know what the protocol is. And you don't have to think about it when you're emotional, when you're in that state where you're not really tapping into your rational part of your brain. So teaching patients how to even think about this, how to identify what are their high risk situations and what are their low risk situations, because over time, we want people to shift this balance. When they're using at high levels, they're typically engaged in a lot of high risk situations. And what we want them to start to shift to is spending most of their time with people, places, and situations that are low risk. They're not going to be triggering, and that they're only going to encounter those high risk situations occasionally. And when they do, they're going to have a plan. So every single week we go through, okay, what's coming up this week? What is the situation that you can see is coming down the road? And then how are you going to handle that situation? Let's come up with 3 or 4 specific concrete plans that you can act on. And then you can keep this in your purse, or you can keep this in your wallet, or you can take a picture of it and put it on your phone so that it's here with you when you're in that situation. The nice thing about this too, even though we're not going to be able to think through every single possible situation that could come up for somebody, it's teaching them that skill that they can then start to do automatically and apply from a generalization standpoint. They're starting to generalize it to more and more situations without having to write down the specific things that are coming up. So this, again, it scaffolds and starts them in the service of learning this skill to be able to identify that's high risk. I'm not going to be able to manage that well. If I find myself in that situation, I now know that I have 4 different ways that I can get out, that I can actually manage that without using. So that's an extremely important thing, and why we want to be reinforcing this for some people. They're early in recovery at a daily level, and then lengthening that to weekly, monthly, and so on. It's extremely useful for them to have that set out, and you can partner it with a schedule, which is another important piece of good CBT. So hopefully that gave you kind of a real quick review of cognitive behavioral therapy and some of the techniques that would be applied under that umbrella.